Over to you, Phil. Mr. Mulenga.
Hello. Thank you so much. Thank you so much, and good evening to everyone. I'm not going to introduce, I've already done the introduction. So today's presentation, it's on cardiac tumors and masses with the echo perspective. So basically, we are going to discuss some few things that we need to check on echo and some of the principles that we need to follow and some basic pitfalls that may be seen. I also try to define what these masses are and basically discuss some few concepts that we need to get as we look at these cardiac masses and tumors. I should be quick to mention that you may not have the definitive diagnosis on echo, not until an histopathology is done on that particular part. So it's very important to note that masses can be seen, but there are certain key things that you need to look at for you to come up with a possible diagnosis. I'll still further discuss some few artifacts that we all know regarding ultrasound and how they present, and basically how we can avoid them by having a good technique in image optimization. I'll discuss some few things of normal variants, that is normal anatomical variants that we need to be aware. At times we see strange things on ultrasound, and we have to be aware that there are normal variants that may present. Some normal variants may also present when there are other pathologies, so they may also be confusing. I'll discuss what true cardiac masses are and how you can tell this is a true cardiac mass, this is none. I'll briefly discuss about the benign and malignant tumors. I'll still stress to say it's not possible sometimes just on echo to say this is malignant, this is benign. However, there are certain features that you need to take even before you do that. Some few differential diagnoses that are possible, I'll still explain them. Whenever I'm presenting on echo, I like talking about some few things that we need to consider as we are practicing echo. I'm aware we are not all practicing echo, others are practicing echo, others are not. But the key message is that we are all in the learning curve. We have to learn and correct each other so that we keep sharpening each other. I'll tell you something, that echo deals with very, very small figures, very, very small figures. So any wrong technique may result into wrong diagnosis. That's one. Secondly, if you don't have a thorough understanding or comprehensive understanding of cardiac anatomy, echo may be tricky to you. The third point is that one needs to understand the hemodynamics of the cardiovascular system if you are to do a good job in echo. And lastly, one has to understand the Doppler principles and when to apply them and how to apply them. I've seen quite a number of techniques sometimes that we do as radiographers, sonographers. Some principle and technique that we do, they end up giving us wrong figures. So with those and their guiding principles that we need to check, they are there in books, the literature, the guidelines. I think those are key issues where we can pick things so that we give at least what we can. We must understand that echo has got limitations, just like the general ultrasound. So having said that, I'll quickly go into the definition of what a cardiac mass is. So basically, cardiac masses or tumors, these are lesions that can be found in or around the heart, and they may present as solid masses, or sometimes they may also present as the anechoic masses, which may appear like cystic or so. Generally, these are incidental findings in the sense that sometimes patients are very asymptomatic and they don't cause sometimes any symptoms that may present. So half the time we find these masses incidentally. However, it's very important to remember that these cardiac masses, depending on where it is, it may affect the hemodynamics of the cardiac circulation. So depending on where it is, this may present with certain clinical symptoms that you may pick on clinical assessment. But generally, the principle is that they less frequently causes these symptoms and you may not see them. For example, you may be having a mass that is basically lodging in the left appendicular appendage. It may be stuck there and it won't necessarily affect the hemodynamics of the left atrium. So you may have such. Others, they may be quite originating from either the posterior wall, anterior wall of either chambers. So they may not give that hemodynamic changes that may come. And the true intracardial and extracardial masses need to be distinguished from what may be presenting as a tumor. These concepts, they are very important as well to understand basically the few principles that may apply for you to get this. And by concepts, I mean, there are certain things that you need to consider for you to suspect either there is a thrombus, or there is a tumor, or there is where, just some few scientific reasons that you need to take. For example, when do I suspect that there is a thrombi? Where am I likely to see a thrombi? The principle is that the thrombi can be caused where there is a low or slow blood flow, which may refer sometimes to as a stasis. Where there is a stasis of blood flow, thrombus formation are likely to occur on that part. So basically, areas where you can find low flow of blood, you are likely to have that. And how do we see that there is low flow of blood within the chambers? You see this echogenic mobile motion in the chambers, which we call stasis. That can also appear within the peripheral vasculature. For example, it's very common to see stasis in the IVC. And depending on your image optimization, you must be aware to say, oh, I'm dealing with this. A patient with poor venous return may also present with the stasis within the IVC, or depending on where that flow is compromised. That is first one. The second one, vegetations are typically on the low pressure side of the valve. I'll discuss when I say a low pressure side of the valve and what it means. The other thing that we must understand is that assessing tumors for size, shape, and physiological significance, it's very key as well. And what do I mean by physiological significant? I talked about the hemodynamics, which is nothing but the flow, the study of the flow of blood within the cardiovasculature. So you find that depending on where that tumor is, it may affect. For example, here is a person with mitral valve stenosis. We know that it simply means the mitral valve may not open to its full extent. So if you are having a thrombus that is just within the mitral valve and orifice, you find that depending on how much flow of blood may flow through that, this may affect the cardiac function, the left cardiac function. And what will happen now is there will be blockage, which will result now into pressure overload within the left atrium. And that may consequently lead to backflow of blood back into the pulmonary circulation. So this physiological significance becomes so crucial whenever you are discussing these tumors. The other things that we must understand is that the common pitfalls. So some of the common pitfalls that may also present is that we have to be aware of the normal variants, and some few normal variants that we may be aware basically comes from understanding or having a comprehensive, thorough anatomy. For example, when you talk about the right atrium, you find that you can find things like the EUSTACHIAN valve, the CHIARY network, you can have the crista terminalis and all those things. They may appear. One has to be aware that I'm dealing with the variants and these may not be pathological. You can go into the right ventricle where you can have the moderator band, the force tendons, and all those. We must be aware of that. Things like those trabeculations that may be so prominent may also sometimes mimic to be pathological features. And all masses should ideally be seen in more than one plane. Again, I'll still insist, never conclude an echo report or echo examination on one view or one or two. Do an exhaustively chambers, do an apical 4 chamber, do the suprasternal, depending on what you are looking at. So never conclude echo just on one view, and not only on one view or plane. Ensure that you apply all the scientific methods that has been stipulated to quantify exactly what you are looking for. For example, if you find that you are having things like there is a mass, apply your color. Apply the possible Doppler modalities that may apply depending on what you're looking at. But the issue is never conclude echo on one view. Try to see in all angles to pick things. I'll again give you a very quick example. There are times when you are scanning pediatrics patients, maybe they are suspecting a defect. In most cases, when you pick an apical 4 chamber, you are likely to have a dropout artifact, which may mimic a defect, either a VSD or an ASD. So what do? You have to go through the subcostal to confirm really if you are dealing with that. Even when you see that, you still have to apply other things like color, continuous wave to quantify exactly what you are dealing with, whether you are dealing with the left to right shunt or right to left shunt. So basically, it's very crucial never to conclude echo on one. Use color flow or intravenous contrast to ensure that a mass is not an artifactual. I should mention here that currently in Zambia, I think we are not so much aggressive when it comes to this interventional cardiac assessment, where you have to inject these intravenous contrasts. But these are things that we can practice and do. But half the time, we tend not to have this time because of maybe one or two things, but we need to be aggressive if we are to practice the real and the real science that we are preaching. So it's very important to take note of that. Other things that we must not be aware in ultrasound is artifacts. These artifacts, we know that these are wrong images that may appear to be real, yet they are not. One of the most common artifacts that we may find in echo, it's a mirror artifact, very common in pediatrics where there is highly reflective ultrasound beam. You are likely to have this. But generally, the principle is that this interaction of ultrasound waves, it's due to the interaction with the beam and the tissue, which may result into this. And artifacts may also appear like masses within the heart, which we may know. How do we improve this image optimization? You really have to work on your nobology skills, you work on your image optimization. And this is also another weakness where we just do things and we don't emphasize and give an optimum image. I've seen some echoes sometimes that we do, it's a difficult echo, but you actually fail to optimize the chambers and we can miss things. So image optimization becomes key to avoid certain artifacts that may come in. Again, imaging from multiple planes, interrogation with color Doppler becomes very, very crucial to distinguish things like tumors, things from true masses and all those things. Very, very key to ensure that. Use of alternative imaging modalities. I think I mentioned that we have to realize that echo or ultrasound in general may have limitations. Again, I'll give a very typical example. Sometimes the patient may come clinically, they are presenting with a possible pulmonary embolism, and the echo may be requested. So the only how far you can go with an echo to pick a pulmonary emboli, it's when you do your short parasternal axis, where you see the main pulmonary artery, the right and the left, on just before the bifurcation, echo is able to go as far as much. So that bifurcation, right to left, right pulmonary artery, the echo is able to see that. But beyond that, you may not see because echo is limited. It cannot go as far as much. What do you need to do? You have to recommend where possible. So you have to be aware that echo may not be exhaustively the modality to help or exclude certain pathologies that may be presented. And it simply doesn't mean then that is the final diagnosis. I think this is a song that we know that imaging modalities, they are limited to what they can do. So those are some of the things that we must consider. That I've already talked about the normal variants, the eustachian valve. We know that the eustachian valve is nothing but a remnant valve during intrauterine life, which diverts blood from the right ventricle straight into the into the systemic circulation. So this is a normal variant that you must understand. And you can only understand this if you know your embryology and your anatomy, cardiac anatomy. This may help you to understand what a eustachian valve is. How does it appear? It appears as a linear echogenic line within the right atrium. And sometimes it's very difficult to differentiate a eustachian valve from the CHIARY network because they sometimes appear the same. Typically, this may appear in 2 to 3% of adults, and this should not scare us as what are we dealing with. Again, I'll still insist to say this may also be another area where these variants, are they affecting the physiological hemodynamics of a particular patient? Crista terminalis, this can also be mistaken as a right atrium mass. Again, this is also a normal variant. Moderator band, this is nothing but a prominent massicular band that runs from the septum running into the right ventricle. And this sometimes can be so prominent, and you must know that I'm dealing with a moderator band. I should mention again that these all normal variants must be excluded on multiple planes so that we know exactly what we are dealing with. You can be having things like the left ventricle force tendons, and you can only know that there is a force tendon when you do your multiple planes with different views. The Cohandan ridge, okay, this can also be mistaken for a thrombus, and this is typically found in the left atrium, just adjacent to the left atrial appendage. You may find that this ridge may also be very prominent. This is also very prominent in cases where there is dilatation of the right atrium. It becomes so prominent, and thrombuses normally tend to start into that. And in other times, you may find that this may also be very prominent in patients, and that should not bring challenges. So having said that, this is how the eustachian valve may appear. It may actually appear as a linear or dividing the left atrium into 1 or 2. So this may appear as a eustachian valve. When you see this apical 4-chamber again, you find that this is not the only view where you can pick this. You can also see this in short parasternal access at aortic level. You can also pick this view on a 2-chamber view where you just want to appreciate the right and the left ventricle and all those. So do your multiple planes so that you can exclude whether you are dealing with a tumors or you are dealing with a pathology. Again, I mentioned that the CHIARY network may also be appearing like a eustachian valve. And you all agree with me that this is also a linear lesion that appears, but this is a CHIARY network. Typically, literature has described this to appear like a web-like network. So one of the things that you must consider is that the CHIARY network may appear like a network-like, whereas the eustachian valve may appear just as a linear because it's a remnant valve that may appear like that. But this is how the CHIARY network may appear. This is also a force tendon within the left ventricle. This was in systole. As you can see, the cavity is reduced during systole due to the contraction of the myocardium, while in this side, it's more prominent now. This is in diastole, where the cavity now is relaxed. You'll find that during systole, it's not well stretched, and one may miss this one. So this also becomes very important that as you do your echoes, make sure you get the nice 2D, a nice 2D, so that you can track back. You work on your frames, you pick it in diastole, and you don't need to rush, because rushing sometimes or clearing the queue in the name of I want to clear the queue, you may miss important things. And remember, our names, they are attached to whatever report that we are making. So try to be meticulous even as you do your reports, because sometimes your report goes and you miss certain things and people talk. So I think that's very, very important to note. And then when you talk about one of the common things that we may discuss is these are myoxomatous. The mitral valve, when severely thickened, can be mistaken for a tumor. Okay, simply because the mitral valve has thickened. I should mention here that literature has continued to say, when do you say the mitral valve is thickened? Typically, they talk about 5 millimeters. I'll explain and demonstrate how you measure when to say the valve is thickened. You consider 5 millimeters. For those of us who have been practicing echo, it's easy to see whether this is thickened, or this is calcified, this is atherosclerosis. Again, there are few techniques that we can work around when you want to say there is calcification, there is thickening, and there is this, so that you don't just confuse things altogether. Other pathological variations in normal structures may include the epicardial fat. This epicardial fat, it's found within the pericardium. Sometimes we may miss this one to be an extracardiac tumor or mass that may appear, but you have to be aware that under normal variants, you may have this epicardial fat that may present. The limbus excretions can also be one of the things that you may consider there. The dense mitral annular calcification, this may also appear like a tumor. Remember, the annulus, it anchors itself on either sides of the septal and the posterior wall. So sometimes it may appear with calcifications, and because of that dense calcification and the appearance, one may think there's a tumor that is seated within there. The hypomatous infiltration, also those may also mimic some tumors that we present. I think I have some images, so I'll show how these may appear like that. So other pseudotumors that we may look at when you are doing your echo, consider that a patient may also present with a pacemaker. We all know that a pacemaker is found in the right atrium. So we shouldn't be surprised when we see any dangling kind of appearance or an artificial appearance. We may be aware, and more importantly, you need to know that you need to go through the clinical notes. You may be dealing with a patient who has been on dialysis, a patient who has had a pacemaker replacement. So all those things becomes key, so that you understand the clinical part of it, so that even as you do your investigations, you are aware exactly what you're dealing with. I think I've always told a story where the first time I saw a mitral valve, prosthetic valve, the patient just came and there was a lot of noise in the chest. So I didn't know exactly what was happening, but when I checked, this patient had a mitral clip and it was making noise in the chest, even to the outside. So be aware also of things like the mitral clip or prosthetic valves, which may also predispose a patient to thrombosis and the infective endocarditis because of that. Actually, it's one of the risk factors of infective endocarditis in patients with prosthetic valves. A patient may also have a valve occluder. These valve occluders, they are normally placed in patients who have had a valvular replacement and the valves are still incompetent. So normally cardiologists, they put this valvular occluder, and you must be aware that the patient may be having a valve occluder. Central venous line, these are patients who are on dialysis. Normally they come for interventional ultrasound. I think of late I'm seeing some of these patients on dialysis. They'll come with a venous line which is right in the right atrium, and you'll find that it's there. So what are the true cardiac masses? The first one I'll talk about, it's a thrombus. We know what a thrombus is. So a thrombus is an intracardiac thrombi. It's very rare that almost impossible to find a thrombus just when you talk about the cardiac, maybe it's in the pericardium and stuff like that. But half the time, the intracardiac thrombi can form in the chambers. It may be thrombus in situ or in transit. And by being in situ, we mean this thrombus may be stuck at one position, or it may be adhering to the walls of the myocardium, or it may be in transit. And you know what it means when a thrombus is in transit, then it's a dangerous thrombus depending on the size, because we don't know where it will head. If it heads into the common carotid, heads into the abdominal, we don't know. But the issue is you may have these two that may present. Risk factors for a thrombus may include, one, atrial fibrillation, which we can explain. These atrial fibrillation, they're basically ectopic heartbeats that may be happening, or there is no synchronity, there is no continuous heartbeat that may be happening there. So there is no proper filling and emptying of the ventricle and the atrium. So because of that dysynchrony, or because of that uncoordinated physiological diastolic and systolic, an atrial fibrillation will present or risk somebody to have a thrombus. That is one of them. So even as you do your echoes, check how is the clinical picture, what is happening there. Sometimes you're also able to see just from the patient as they present. You are likely to have a patient with a thrombus who presents like that. Mitral valve stenosis. Again, I mentioned about understanding the physiology. Why is mitral valve stenosis related to a thrombus? The simple reasoning is that when the mitral valve area is reduced, remember the normal mitral valve area is 4 to 6 centimeters per squared. So the narrower the area, which you can quantify with echo, the narrower the area, the more severe the stenosis is. So we want our left atrium to empty whatever it's receiving from the pulmonary circulation to the left ventricle. So if the time, and there's a specific time, if the time of emptying from the left atrium into the left ventricle is compromised, definitely there will be poor emptying of the left atrium, and that will create a conducive environment for stasis of blood, and formation of thrombus may occur. And in most cases, patients with severe mitral valve stenosis, they are actually prone to have that. And some of the causes of mitral valve stenosis could be many. One of them is RHD, rheumatic heart disease, or you can just have diseased valves, which may be calcified, and they are unable to empty this blood from the left atrium. So one of the predisposing factors, it's that one. Hypercoagulant states. So these are patients who may be in a state where they are prone to have thrombuses. A good example I'll give is pregnancy. During pregnancy, you all agree with me that during pregnancy there is a lot of hemodynamic changes, physiological changes that happens, quite a number of things that may happen. So these hypercoagulable states may be men. Others may be on certain medications, and they are predisposed to have certain conditions, or they may also be presented to that. But the typical example is during pregnancy, and then patients may have those. You agree with me that sometimes we see pedoedema, pitting of the lower limbs and stuff like that. This is due to poor venous return, due to pregnancy and all those things. So those may also present like that. So most common location of a thrombus, there are typically three. One, it's in the left atrial appendage, and the left atrial appendage, it's a normal anatomical variant that you may find. So this is a ridge-like appearance that may occur in the left atrium. And because of its morphological structure, you find that the flow of blood within the left atrial appendage, there is low flow of, the speed is very slow. So thrombuses tends to lodge into the left atrial appendage. So that's one of them where you have to look for that. In the left ventricle, typically when a patient has got maybe a recent myocardial infarction, or even a chronic dilated cardiomyopathy, you find that the contractility and the flow of blood within the left ventricle may be compromised. And typically apical thrombus, they are very common just on the apical. And you also find that these thrombuses, again, they tend to be adjacent to where the infarction had occurred, meaning that particular segment of the heart, depending on which segment, you find that the flow of blood around there may be compromised. So you find that you are having a thrombus right at that particular time. What do you need to do as a sonographer, as a radiographer, when you're doing an echo? Make sure you maximize your views so that you don't just conclude, oh, there is a thrombus just in an apical 4 chamber. Ensure that you also check, can I see the motion of this particular valve in this view? Maybe do a short parasternal axis and then check the motion of the myocardium. Remember, the myocardium, it's one muscle, but it contracts with those imaginary segments that are there. So you have to relate your maybe your short parasternal axis at different levels, and then do your apical and relate with whatever you are seeing adjacent to that particular portion. Remember, the segment that is not functioning is direct proportion to the perfusion of blood towards that. So depending on the ischemic or severity of that particular ischemic attack that you have, that may also affect that. I mentioned about the prosthetic valves. Remember, these, depending on what they are, patients tends to be prone to have thrombuses around the prosthetic valves. Remember, these are artificial valves, and I don't know if they are latest valves but technically patients, literature has shown that they are more prone to this, together with infective endocarditis. So patients tends to have thrombuses with that. So this one, I'm just trying to show, this is the left atrial appendage. It's a ridge, as you can see here. But if you can see how this is lodging, it's just lodging within there. So it's a ridge that we are trying, and it protrudes into the chamber just like that. So you can see, for you to delineate this, they had to use a echo contrast, which demonstrated highly a big thrombus within the left atrial appendage. So again, I talked about a thrombi within the left ventricle. I think this one was after the treatment with some anticoagulants, but still this was still picked as a thrombus. I think it had to take some time for it to dissolve, but typically this was after the patient had a recent ischemic heart disease, and it was picked as such. Again, this was a patient after TAKOTSUBO. This is a condition named after this professor, which is related to stress and stuff like that. But you can see that empirically, by eyeballing, this appears to be dilated, though not quantified. But TAKOTSUBO, it's related with the cardiomegaly and dilatation of the left ventricle. But you can see that you have this thrombus that is up in the apical portion. And you may ask why they like lodging here in the apical. Remember, this is the most dependent portion of the left ventricle. In echo, we flip the images. So much as it looks to be more anterior, but this is the base. Sorry, this is the most dependent portion, because the base is this side and this is the apex. So because of gravity, so they will appear to that. This was a prosthetic valve. How do I know I'm dealing with a prosthetic valve? Artifacts comes in. So typically prosthetic or clip, they give this reverberation kind of artifacts, which may be seen. It's not a typical reverberation, but you can see that you have these shadows that are coming down here. This is due to repetitive deflection of the ultrasound beam from the clip that are coming here, because these are valves and there's that repetitive. So it gives you that kind of appearance. So you may find that you can have thrombuses around there that may appear This was also a thrombus. This was a PEE. This was a thrombus within the left atrium, nicely well delineated. This is the posterior mitral valve, and you can see how it was lying just within the chamber. This is an odd thrombus. You can see that it looks more echogenic. By the way, sonographic features of a fresh and an odd thrombus must be commented, whether it's a fresh or an odd. A fresh thrombus is more anechoic, while an odd one tends to be more echogenic. Sometimes with the calcification may also occur there. Where won't I find the thrombus? So there are places where you cannot find the thrombus, and others are exceptional, others you may not find. Typically, you cannot find, it's very rare to find a thrombus within the valves. The reason is very simple. The valves are the most mobile structures within the cardiac structures, so they are always in motion unless there is something wrong with the valves. But typically it's very rare to find the thrombuses within the valves. Only with the two super infected thrombus in cases of endocarditis. Remember, in cases of endocarditis, there is compromised mobility of the valves. So you find that, yes, you're going to have a challenge when it comes to picking those. The other things is patients with assisted valves, which I've already mentioned that because of poor left ventricle function, which is an LVF failure, this patient may also present with thrombuses. And typically, you find that in cases of left ventricle failure, patients may have a DCM, dilated cardiomyopathy, and blood ejection and cardiac output is compromised. So you have to be aware of those two predisposing factors of thrombus. One of them is that the speed of blood flow, that can be a predisposing factor. Thrombogenic surface, those are places where there is a slow flow of blood within there. Again, I've already talked about DCM, dilated cardiomyopathy. The other thing is these terminologies, they must make sense to anyone who's practicing ultrasound. Why is the relationship between a thrombus with dilated cardiomyopathy? The simple reasoning is that when there is dilated cardiomyopathy, in half the time, 80% of these patients, they are having systolic failure. And this systolic failure simply means that blood cannot be ejected out of the left ventricle as expected. So there is fluid overload or pressure overload within the left ventricle. Again, this will still compromise the circulation and hemodynamics, and this results into a thrombus. LV apical thrombi, I've already talked about this because of its dependent portion, and in cases where a patient has got an infarction site, so they will tend to lodge, they follow the infarction site. And I mentioned about why an infarction site. The scientific reasoning is that a specific segment of the myocardium is supplied by a specific territory of blood supply. So when there is an occlusion, for example, with the LAD, which supplies most of the IVS, the descending artery, most of that, you find that there will be compromised motion on that, and that could be the infarcted side or the infarction side. So thrombus may thrive there. Thrombuses are accompanied by regional warm motion. And again, as you do your echo, pay attention to the motion. Don't just talk about motion. Do we understand the radial motion? Do you understand the circular motion? Do you understand the circumferential motion? So that motion can give you a clue on what is really happening within there. Again, this is just an apical thrombus that I've talked about. So when do we suspect, or when you diagnose a thrombus, what is it that you're supposed to talk about? Like I mentioned, talk about, is the thrombus fresh? Is it odd? let it be known there. Why is it relevant? Why is it important to talk about whether it's fresh or late? An old thrombus is better than a fresh thrombus. The reason is simple. A fresh thrombus, you are likely to have that fresh thrombus to be in transit. And we know what that means because it may find itself anywhere and cause a sudden death to that particular patient. So older thrombuses appearance, it may appear organized, echogenic, and less mobile. And of course, either fresh or old thrombus, they are not good thrombuses, but at least you have to describe it where it is. Is it mobile? Is it like this? Is it what? So that you guide the surgeons and the clinicians so that you know exactly what to do. A fresh thrombus will appear homogeneous and echolucence due to that freshness. It will have irregular borders because it has not yet organized. And then it has mobile components. Remember the properties of blood when it's just clotting and stuff like that. So it will give you that mobile components that, and sometimes you may actually miss it if it's flesh. And if it's fresh, you may also, depending on the equipment that you are using, you may actually miss it. And there's nothing you can do, you've missed it. So it's very tricky. And this principle, again, applies also to peripheral vascular ultrasound. You may miss a fresh thrombus simply because it's fresh and it will just be there. The thrombus is in the right ventricle. Also, it's rare to find a thrombus in the right ventricle. The simple reasoning is that the poor right ventricle is a common cause. So if you find a thrombus in the right ventricle, it may be that you are having this poor function right ventricle. And again, how do you confirm that you are really dealing with a poor function? You use other parameters to quantify whether the function of the right ventricle is okay. So much as you have this knowledge, but apply also. Use things like TAPS, which is one of the current methods we are using to quantify the function, the systolic function of the right ventricle. Use your TAPS, apply, and then check whether really you are dealing with. It goes back to what I'm saying, what I've been emphasizing. Never conclude your diagnosis or your comments or your findings on one view. Because if you say the right ventricle is failing, what is your guidance? What is your scientific reasoning? Are you able to defend that really the right ventricle was not functional? That could be the cause of this. So echo gives you all those parameters to use. Factors predisposing right ventricle thrombus may include atrial fibrillation, which I've already mentioned, enlarged atrium, and the poor LV function. What is the explanation about the enlarged atrium? You can have tricuspid regurgitation. We know the implication of tricuspid regurgitation is that there will be a backflow of blood back into the right atrium. Sometimes if you have poor venous return, in cases of pulmonary hypertension, there will be congestion of the right ventricle. And this may also, again, predispose the implication of the right ventricle. What is the explanation that the right ventricle failure may result into a thrombus in the right ventricle? The implication is that failure of the left ventricle may actually transmit the same poor backflow of there will be transmission or the backflow of blood back to the left atrium, the pulmonary circulation, and back to the right side of the heart. So you can have the poor function or fluid or pressure overload due to the left ventricle failure because of that backflow of blood that may present on a patient. I think I've already explained about how atrial fibrillation may present. What are the true masses that we can call? The true masses are basically categorized into malignant or benign. They may be either primary or secondary tumors. So what are those primary or secondary tumors that we may find? One of the common benign tumors that we tend to have, and I should mention here again that these primary tumors may arise from the heart. It's very rare, but they normally arise from the heart. are rare and only about 25% are malignant. So it's very rare sometimes to have malignancies. But 90%, like I mentioned earlier, these are incidental findings, and we may not actually know because patients, they will be asymptomatic. The arterial tumors are intracavitary in the sense that they are within the cavity. The ventricular tumors, they tend to be intramural, that is within the myocardium, and they may present as such. You can also have, if a cardiac tumor is suspected, so in case of a suspected tumor, describe the mass as a person doing the ultrasound, investigate any associated hemodynamics. I think I've been singing now about this, so I don't need to reemphasize again, but investigate any associated hemodynamics. Where is it? What is happening there? Is it stuck? Is it, talk about it, let it come out. And then things like pericardial tumors, they may cause the pericarditis or pericardial effusion, depending on what it is. We know that malignancies tends to cause these pericardial effusions and others. Intracavitary tumors can impair the normal flow. I think I've already I've emphasized on that point. Sometimes extracardiac tumors may be mediastinal masses, and these can displace the normal cardiac structures. So you really have to be very careful. You may be dealing with a compressed chamber, either the right or the left, and you may not have an intracavitary tumor, but you may be having a mass that is arising from the mediastinum. No wonder it's recommended when you are doing your echo that your depth of scanning should be around 2 to 3 centimeters beyond the cardiac structures, so that you also assess other possible extracardiac masses or other pathologies that may present when you are doing that. For example, if you are doing your parasternal long axis, for those who are practicing echo, you tend to see the descending aorta, and seeing the descending aorta may, Sunny, can you go? Okay, can you sleep? You tend to have the descending. So sorry for that. So you tend to have extra. I'm so sorry for that. So you tend to have extracardiac tumors that may also present, and I'm so sorry for that. So you tend to have extracardiac tumors. So the depth of scan must be well understood, so that you see other extra cardiac masses that may appear there. So technique image optimization is very crucial in every step that you are doing your scan, so that you know exactly what you are dealing with. So most common tumors of the heart, they are the MYOXOMAS, about 50%. They are MYOXOMAS, and 75 to 85% literature continues to say cases involves the left atrium. And this is quite a big figure, and the echo is very, very specific when it picks a mass like this, but the sensitivity may not be all that. And again, I'll mention that you may see a mass, but the definitive diagnosis again will be histopathology. So you may just give your differentials and say what it is, and typically measure it and give you parameters of echo. And patients with MYOXOMA may present with fever, they may present with fatigue and malaise. You need to explain each and every part. Why a MYOXOMA patients will present with that? Because if you just cram them and you don't know exactly what these patients may be presenting with, it may not be very helpful. What are the characteristics of a MYOXOMA? One of them is that they are often heterogeneous. By heterogeneous, we mean they tend to have mixed pattern, and they're irregular in shape, and they measure specific size that we will see how you can quantify them. And often these patients, they tend to be asymptomatic. You won't even know that they're having these tumors. And when a myxoma is diagnosed, please comment on the location, the size, obstruction, in the sense of are they affecting any hemodynamics and which side are they? And normally myxomas pathologically, they originate from the fossa ovalis. So they tend to adhere to the interarterial septum. So those are some of the things that may help you to pick. Pathologically, when you read about the pathophysiology of the myxomas, typically they tend to originate from that, and there's a reason for that. So this is the first myxoma that you may find. If you look at it, it can be anything. It can be a thrombus, it can be this, it can be that. But I think the whole idea is that to realize the type of the mass and the tumor, what you're dealing with, so that you know, because if anyone can say this is a thrombus, no one will argue. What makes you think this is a myxoma? Apply things like color, apply things like contrast, echo, so that you exactly see. So you find that they tend to have flow within themselves, despite being benign, but they tend to have flow, while a thrombi may not have that flow. And then you can also see this. This was a thrombi and not a myxoma. I deliberately had put this one because this was, anyone can say this is a thrombus. It's possible to say that. Sorry, anyone can say this is a myxoma because of its location. Remember, it's just within there and just adjacent to the AS. But this was a thrombus, our left ventricle, left atrium, and that in apical fourth chamber. This one, I was just trying to demonstrate about that one. This was also a myxoma again. You can see this is in diastole, end diastole. This is in end systole. Still, that was it. Again, this was a myxoma in apical fourth chamber with slightly over gain. And again, I should also mention here that image optimization. Whenever you are doing your echo, optimize your gains. Don't let your image not to have this over gain, because you can miss a thrombus. Make sure your chambers, they are dark. They are dark, so that you don't have an image like this. This image is not a good image because it was overgain. There was overgain, as you can see on this image. So make sure your chambers are dark. Optimum image optimization is very key, so that you delineate whatever has to be demonstrated. What is the prevalence of myxomas? About 46% of adults are affected, and age plays an important role in the prevalence. Mostly children are affected, about 15%. Sorry, adults are more of 46% and children about 15%. They are affected. And then you also have lipomas and rhabdomyoma. So they're in that categories. Papillary fibroelastoma, most common tumors of the cardiac valves. These tends to be less than 1 centimeter in diameter. I think I have one, so I'll show you. Common seen on the mitral valve and aortic valve. They tend to be very, very small, so you can miss it. You may think this is just a thickening. You may think this is just a normal valve, that is, but they are quite small. 1 centimeter, you can miss it. It's a subvalvular, rarely seen on the free wall, but they tend to be more on the subvalvular. Typically, they are pedunculated. They tend to have a stalk, and then you see them like. So this is a papillary fibroelastoma, which is just there. And if you don't pay attention, of course, you know there's something abnormal, but you can see that this was confirmed as a fibroelastoma on the anterior mitral valve leaflet. This is our anterior mitral valve leaflet with good image optimization. This was also a papillary fibroelastoma. This is a papillary fibroelastoma, as you can see. So you can measure it from there to there, or you do that, but typically it tends to be less than 1 centimeter. That is another fibroelastoma. Other benign cardiac tumors, lipomas, fibromas, hemangiomas, and such. This was a lipomatous hypertrophy. This was on the subcostal view. Okay, left subcostal view, sagittal. This is what you get. It was not a coronal, but sagittal. It was a sagittal one view. So you tend to have those. So you can see this hypertrophy lipomatous just within the AIS, the interseptum, anterior septum. Cardiac malignant tumors, these are less compared to the benign, normally presents with pericardial effusion. And then typically the criteria to diagnose a malignant, you have to look at those standards. One, they are expansive in growth. They tend to be irregular, can affect more than one chamber because of its malignance. They are irregular in borders. They grow along the structures. And typically they give this pericardial effusion in 90% if present. And they've got this rapid growth that they may present with them. So these are some of the things, and some information here, you can only pick them through maybe previous scans or previous echoes or patient presentation. And basically sometimes the clinical presentation, but typically they can affect more than one chamber. And typical location of these malignant tumors, right atrium, right ventricle, pulmonic artery, intramyocardial, and sometimes even in the IVC, they may present like that. I talked about compression of the chambers due to extracardiac masses. So when you look at this, there was a mass here which was compressing the right atrium. What is the implication? The implication is that this may affect the hemodynamics of the right atrium. So you can have this extracardiac mass which is pushing or compressing the right atrium. So those are the malignant tumors. Establishing a differential diagnosis, I think I've talked a lot about the location, the mobility, and the visual appearance. What is the take-home message? The take-home message is that when you diagnose a thrombus, comment whether it's fresh or it's old. Always differentiate a thrombus from a true artifact. Always check if the patient has a myocardial scar. This may help you to know exactly what you are dealing with. Patients with poor left ventricle function and right ventricle function may also be predisposed to thrombosis and other hemodynamic changes that may present. Patients with the hypercoagulant states may also be predisposed to certain changes of the hemodynamics, and sometimes difficult to determine what kind of a tumor only after biopsy. And this should be understood by anyone doing an echo. So as we do our echoes, we must remember that these echoes that we are doing, it's very important. You may not find some of the things that we are talking about, but you may help an individual by doing the correct things and give at least some of the parameters that may help a patient to seek further management of that. So thank you so much for your attention. At this juncture, I'll hand over to the moderator, Madam Trines. Thank you so much.
Thank you so much, Mr.